So I already said that. So the risk factors, the same risk factors as DVT. I won't repeat that. So what are those three again? The varicose triad. We have endothelial injury, venous stasis, and hypercoagulability or altered clotting. Now, for this chapter, it will only talk about a clot caused by a PE caused by a clot. Because there are other sources of a PE, could be formed by an air, fat, amniotic fluid, or even septic emboli. Now, again, for this chapter, it's only going to refer management-wise, it will refer only to clots, okay? So PE is caused by a clot. Now, since this is, imagine your anatomy, why isn't this called pulmonary infarction? Because this is the same clot that causes a stroke or a heart attack, and it's obstructing an artery or multiple arteries. Why is this not called a pulmonary infarction? Why is it called pulmonary embolus? Why can't we call a stroke cerebral embolism or
It's not.
a heart attack a coronary embolism? Why not?
It's not blocking oxygen in the blood.
It's blocking multiple arteries.
Travels, it's not lodged over here.
No, it's lodged. It lodged in the terminal pulmonary arteries.
What's the same thing?
It
They
blocks.
just don't call
It
that.
blocks an artery.
It's the same thing.
So why is it this an infarction? Why doesn't the lungs die? In the heart attack, the heart dies. The stroke, the brain cells die. Why doesn't this kill the lungs? However, the patient will die here, but the lungs will live though. Why?
They don't receive oxygen.
Hmm?
Because they don't receive oxygen.
The lung has oxygen. Or is it?
Okay, the answer is based on physiology. Are the pulmonary arteries perfusing the lung tissue? No, because in the first place, what kind of blood are the pulmonary arteries receiving?
The oxygen.
They have no oxygen. They're going to the lungs to get oxygen.
Oxygen.
So the problem here is hypoxemia
Mhm.
because the blood goes to the
Mhm.
pulmonary arteries, goes to the lungs, but comes back empty-handed when they return to the left side of the heart. Okay, so that's the problem. Because the lungs are actually perfused by the bronchial arteries, which
Mhm.
arise in the descending aorta. So the lungs do not perfuse via the pulmonary arteries. They perfuse via the bronchial arteries. Okay, so that's the reason. So can pulmonary infarction occur?
Yeah.
Yes. However, it's extremely rare. So the problem here is, as I described, so blood goes to the lungs, but not all of them returns with oxygen. So those blocked areas, of course, cannot reach the lung tissue, correct? Cannot reach the alveoli because they are blocked. However, there are still open pulmonary arteries because there are hundreds of branches. So it can still perfuse somehow, although not 100%. So the patient undergoes hypoxemia, and that's what causes the patient's symptoms. So therefore, as described here, this results in a ventilation perfusion mismatch, meaning there's no problem with ventilation. The patient is breathing okay, but it's a perfusion problem. Okay, there's not enough blood getting to the lung tissue, to the capillaries of the alveoli. So there's of course hypoxemia that results, and that's what will kill the patient. Now, the patient's mortality will vary depending on what category of PE does the patient have. There are three categories. We have low risk PE, meaning there's a clot in the pulmonary arteries. However, it's either non-occlusive, meaning there's a clot there, but they're not obstructing blood flow. Or there may be a few clots, but not enough to cause hemodynamic problems. In the second category, which is submassive PE, a submassive PE Yes, there's significant hypoxemia. The patient has symptoms. However, they are hemodynamically stable, meaning they're not going into shock. Okay, the blood pressure is within normal. However, the oxygen is low. Okay, so they need treatment. The most fatal is a massive pulmonary embolism. So this is not only large clots, but multiple large clots. This will cause death. What type of shock can result here? Obstructive shock. Okay, so massive PE, massive pulmonary embolism, can cause obstructive shock, killing the patient. Nobody survives a massive PE, right? Because the patient, well, I shouldn't say that because there are miracles, like I said. So patient will go into shock, however, and the only treatment there is just like stroke. Patient will receive a thrombolytic. Okay, so thrombolytic is always considered. Or if there's any contraindication to a thrombolytic, then it'll be surgical removal of the clot or clots. Manifestations, again, depend on the category, on the size and number of the pulmonary emboli present. So most patients, especially submassive and massive, of course, there is dyspnea. Patient can't breathe. There is chest pain. Okay, and then the chest pain is described like this. So it's not really hard. I mean, it's not easy to distinguish it from a heart attack or a from pneumonia, for instance. Okay, so similar type of chest pain. Let's go to the diagnostic testing shortly. So other manifestations are anxiety, fear, or collectively these two. Anxiety is called anxiety and tachycardia. Collectively is called sense of impending doom, meaning the patient feels like, oh, I'm gonna die. Okay, there's something wrong. I feel like I'm gonna die. Okay, so they can't explain it. So all three will have that, including the low risk PE, even though they have very mild symptoms, but they will have the same feelings of apprehension, or again, feelings of impending doom. As already mentioned, they resemble other conditions such as heart failure, heart attack, or pneumonia. So the patient must be diagnosed as soon as possible. Because we can't tell right away whether it's a heart attack, pneumonia, heart failure, or a PE, we test for everything. So blood draws will be done for D-dimer, BNP levels, and for a PE, of course, that would be D-dimer. Once D-dimer is seen as elevated, the patient is sent to CAT scan right away. So CT angio will be ordered. Yes.
What if it's a fat embolism? Would the D-dimer still show up in the feed?
Again, no. Again, the discussion here in this chapter will only be for a PE caused by a blood clot. Okay? If it's fat embolism, no, D-dimer will not be elevated because it's not a clot. So once again, D-dimer is elevated, the patient will be sent to CT angio. What does CT angio entail? Pulmonary, angiogram. What does that include?
Contrast.
A contrast. Okay, so if there's evidence of kidney injury, then that's an automatic contraindication, correct? So the alternate is a VQ scan. VQ, the name is ventilation quotient scan. Another name is ventilation perfusion scan. It's a nuclear medicine test. So instead of injecting an IV dye, for which the patient has a contraindication, the patient will be given a radioactive gas. So the patient will go to nuclear medicine. They'll be given a mask, asked to inhale the radioactive gas, and they'll still undergo a scan. So instead of going through the circulation, they'll go through the pulmonary side. So whichever section of the lung does not show the radioactive dye, there's the blood clot. Make sense? Okay, meaning the easy way would actually be injecting a dye And then when you take a picture of the pulmonary circulation, whichever part of the pulmonary circulation has a blockage, you'll see, there you are, okay, or there you guys are, okay? So if it's multiple clots. Since we can't do that, then we go through the other way. We have the patient inhale the radioactive gas. There will be pulmonary edema here as well, which will explain why the patient will have some pink frothy sputum, because what will cause the pulmonary edema here? Because remember, if the arteries are blocked, what happens to forward blood flow from the right side? Okay, so the right side will have congestion, correct? So that will explain the edema that will result here. I already described the VQ scan. Yes. I already said, if the patient has evidence of kidney injury, yeah, so that's a contraindication.
So just the allergy to shortness of breath.
No, AKI. The patient
that's the
has
AKI.
evidence of AKI. Management depends. What category of PE does the patient have? If it's low risk PE, meaning what is low risk again? Tiny clots, okay, small, not causing any hemodynamic problems at all. Patient has low oxygen, we can give them oxygen. So remember, what will the body do after a clot is formed? It will get dissolved, okay? It will dissolve the clot eventually. It will take a long time though. So until then, what can we do about the clot? You have to keep it from getting bigger. Okay, so prevent it. Remember what was the goal in DVT? To prevent it from the extension, right? We don't want that clot to extend. We don't want it to, prevent new ones from forming, right? Because remember, the patient had risk factors, the same thing as DVT. That's why they had this blood clot. Okay, so that's the goal. If it's a low risk PE, treatment is anticoagulant. Okay, keep the patient's existing clot stable and prevent new ones from occurring, and then just allow the body, it'll dissolve it. Okay, now how long the anticoagulation, that's not our problem, that's the doctor's decision. Okay, so most low risk PE, the patient will be given a low molecular weight heparin, okay, or maybe nowadays, because now we have 10A inhibitors, it'll just be placed on an oral 10A inhibitor and for a specific period of time, and then that's it. Okay. Now for a submassive PE, the one in the middle, of course, that will require long-term anticoagulation, minimum 6 months or longer. Again, how long exactly, the doctors follow a scoring criteria listing all the risk factors based on the Virchow triad, endothelial injury, venous stasis conditions, and hypercoagulability. And then when they meet a certain score, then they assign the period of anticoagulation. For massive PE, these patients are unstable. They all go to ICU. They may or may undergo thrombolytic therapy, or both. They could have surgical removal as well. Now, most massive PE patients go because of the sudden nature of the condition, meaning onset is like this. So they usually go into cardiac arrest. And of course, cardiac arrest will entail ACLS, so patient will also be revived, okay, at the same time. Okay, so that increases the mortality, as you can understand. And the patient may go into cardiogenic shock as well, in addition to obstructive shock. So we already know how to dissolve the clot. So same thing as the stroke patient, different dose though. This is not dose the same 0.9 milligram per kilogram. It's a different dose. I'm not familiar with the dosing for PE. And it's not discussed here either. All right, and then if needed, then the patient will be on mechanical ventilator. Okay, so we'll insert an airway and then mechanically ventilated. And here's the embolectomy, okay, the surgical option. If this patient survives and they are, for example, I mentioned the filter already last week, yeah?
Yeah.
Okay, so if there's a contraindication for the patient to be on anticoagulation, then there's a non-pharmacologic intervention, which is the IBC filter, which obviously is surgically implanted in the inferior vena cava. And this thing has a 98% effectivity of preventing future PEs. The 2% failure rate is if the clot forms above, which is in the superior vena cava. There is no SVC filter. They say it can't be done. They can't anchor it if it's because of gravity, obviously. So for so low risk, again, already described, they'll be on either a oral anticoagulant, usually a 10A inhibitor, or short-term low molecular weight heparin injections. Here for us, short as 10 days, okay, if it's a low risk PE. And as long as the doctor determines that the risk factor, meaning the patient doesn't have the varicose triad, or if they did, it was temporary, okay, so let's say the patient just had PE because they were on a consecutive 16-hour flights, for instance, overseas, okay, so that was a one-time thing, right? It's not like they're traveling every day, so they're only given anticoagulant for a short period. It is a picture of a IVC filter. These are the 10A inhibitors, again, also known as DOACs, direct oral anticoagulant. We got dabigatran, fondaparinux, rivaroxaban, apixaban, edoxaban. All right, so let's discuss this option here. If the patient is on, usually this is in submassive PE category. So let's say the patient has a high risk. Okay, so let's say the clot was from a valve disorder. So in which case it's a valve disorder, only warfarin can be used. Yeah. Okay. So if warfarin is the option, the patient will have to be on a dual therapy. The patient will be given IV heparin right now, today, and on the same day, they'll be started on their warfarin. Now, warfarin is an anti-vitamin K, correct? It's a vitamin K antagonist. Vitamin K is needed to form which clotting factors again? Okay, we mentioned it last week. Okay, so go back to the DVT section. Okay, so there were 4 vitamin K dependent clotting factors, correct?
Yeah.
Okay, so once those are inhibited, because now you're taking warfarin, then no more clotting. Yeah. Now the problem is warfarin will start working today, meaning beginning today, those 4 vitamin K dependent clotting factors will stop being produced. However, there are circulating clotting factors already, or they're already in the bloodstream. So will warfarin provide the anticoagulation needed today? No, it will provide it several days later. We don't know how long, because each person will metabolize this drug differently, and we don't know how many of the clotting factors are already in the bloodstream. So until then, when does the patient need anticoagulation? Today or this coming Monday? No, they need it today. So we have to keep them on heparin. Heparin will provide immediate anticoagulation, so they'll be on an heparin infusion, correct? And at the same time, they'll take their warfarin dose daily. And while on heparin, of course, what do we monitor every 6 hours? PTT. Okay, we monitor PTT to determine the dose because the dosing for heparin IV is based on the PTT level. And we draw, of course, every day we draw INR to monitor whether we've reached the therapeutic level for warfarin. Okay, so that's it for, we don't know how many days this will be. For some people, it'll be 2 days. Some people, it could be a week. All right, so we don't know. So until then, until we reach the INR target, which is for PE, it's a minimum of 2. 2 and 3 is the goal. Once we reach 2 and 3, then we stop heparin, patient goes home on warfarin. Any question on that? Okay, so think of it as the heparin use here will be a bridge until we reach our warfarin target. I mean INR target.
Administer medication to help out with the
Warfarin. Yeah, take warfarin.
for the factor, chronic factor, or warfarin for the
No, warfarin is the anticoagulant.
what was it about the circulating clotting factor? Don't know.
No. They're already in the bloodstream, meaning they were made last week, yesterday, okay, until we took the warfarin. So beginning today, when I take my first dose of warfarin, my liver will stop making those 4 vitamin K dependent clotting factors. Yeah, today it'll stop because I'm taking an anti-vitamin K drug. Okay, so I don't have vitamin K anymore. So the warfarin starts kicking in. No more vitamin K, no more of those 4 vitamin K dependent clotting factors. Okay, but like I said, those 4 clotting factors were already released yesterday or even a minute ago, okay, before I took the warfarin. So until they all leave the body, I have to stay on heparin because I need anticoagulation now. Okay, warfarin can't give that to me right now. I took warfarin, but it'll take a while before it starts working. Okay, its effects won't be evident until several days later. Until then, I stay on heparin. Okay, so that's what I mean by it's a bridge. Okay, so until I'm ready, I'm gonna be on heparin. Okay, because heparin will give me anticoagulation like right now. I can't go home until my INR is 2 or 3. Right. So until then, I stay on heparin and warfarin at the same time.
So desired is 2 to 3.
Minimum 2 to 3. If it's a recurrent, so let's say this is my second PE, the target will be higher. It'll be 3.5 now, 3.5 to 4. If it's a recurrent PE, doesn't matter how many times. If it's more than 1, target, it automatically becomes 3.5 because you have a higher risk of PE. You've had it more than once. Next time, you may not live anymore. Okay? Next time could be a massive PE. You understand? Okay. So for monitoring anyone on anticoagulation, of course, you prevent bleeding, right? So, or monitor early signs of bleeding. For thrombolytic therapy, I won't repeat this, same precautions, same observations. Okay, watch for bleeding, especially intracranial bleeding or GI bleeding. For chest pain in PE, the options are positioning, or the patient will be given opioids. Okay. And then oxygen therapy, target is 95% or better. You have to relieve anxiety. This is anxiety-provoking, scary event. Patient dodged a bullet here. Or a bullet grazed their ear. Okay?
So they will get
Yeah, and then chill out pill. Yeah, chill pill. Xanax, alprazolam, okay, or diazepam. And that's it. Any questions on PE?
And under management of pain, it says 74-hour position. Maybe $5 or.
Whichever one. So
You
if
can
it,
tolerate.
yeah, so whichever position the patient breathes better at.
So there's no right or wrong.
Because this is a breathing, not a blood pressure problem. All right.